This is Emilio Fentanes with the First Committee interviewing prominent SCCT members, and I have the pleasure of being with Dr. Hamilton Craig. And we're going to ask him a couple of questions about his involvement in SCT. Dr. Craig, how do you anticipate this participating in this meeting will impact your practice?
I think, I'm from Australia and New Zealand, and I think the CAD-RADS is a huge development in terms of guided, structured reporting. I think it'll help a lot of practices as well as family physicians and people who refer for CT to standardise the information that they get, and that will help guide treatment decisions.
Excellent, sir. Now, as far as the widespread use of CT in the emergency department, what do you think are some of the clinical barriers for its clinical implementation?
The real world is, this is right, it's ready for prime time. It's the right test. If you want to know if someone's got coronary artery disease, you should do a test for imaging the coronary arteries. But in the emergency room, the challenge is good heart rate control, and no matter what scanner you have, you still need to beta block these patients or use ivabradine in combination to get good quality images, because it's good quality images that guide good treatment decisions. The barriers, I think, are the referrers. I think the ER physicians need to be enabled and possibly taught how to read CT, not as more of a level 1 thing, so they're familiar with the technique and what it can offer. So we need to educate the referrers and encourage them to use this technology, and we need to educate the cardiologists to be comfortable with discharging people on that basis. So the evidence base is there. We've got 4 large randomized prospective trials, including ours from Australia. So we know that it works, but we need to start doing it.
Excellent, sir. Now, what is one of the most exciting developments as far as cardiac CT that you have seen at this meeting so far?
I think the Brexit is pretty big, but that's not really CT related. But it may affect Scott Hart. I don't know. I think FFRCT is a big thing that's been around for a little while now. But the developments is that it's becoming more and more close to being in line or very short time frames to be processed, so that you can actually start using FFRCT for treatment decisions, not just in an observational context by sending it away to a black box and waiting for a week to come back. So I think this is going to be exciting when this technology is developed, and when the vendors also have their own algorithms. I think Cohen Neiman's going to talk about CFFR, which is the Siemens platform, which is inline point of care, and the early data on that are promising.
Excellent. Well, thank you very much for your time. We appreciate all of your input, and we hope to see you around.